Good evening, everyone, and welcome to the latest session of the Injury Rehab Network. We're delighted to have Professor John Ryan with us this evening to discuss abdominal injuries in sport. Before we do get going, as always, we'll just run through a little bit of housekeeping to make sure that the session this evening can go smoothly. If you could introduce yourself in the chat, that would be great. It's always nice to see the professions and countries that we've got represented. So do let us know where you're tuning in from. As always, we'll issue certificates of attendance to those of you joining us live this evening. If you are watching this on the recording, unfortunately, we can't issue one to you. The session will last around 40 minutes, 30 to 40 minutes, and we'll follow that up with a Q&A. So please do post your questions in the Q&A for John. Have a look at what's already been posted and give a thumbs up to any of the questions that you like the look of, and we'll be taking those in popular order towards the end. If you could just make sure that questions aren't posted in the chat. If they go in the chat, they'll get missed. And we'd very much like to put them to John. I'm going to hand you over to Andrew, and then we won't take up any more of your time, and we'll get you to our guest speaker. Andrew.
Thanks, Ollie. Evening, everyone. Apologies to those who've sort of heard our introduction before. I'm Andrew. I lead on our work in sport at Steriplast Healthcare. So we're a medical supplier based in Manchester. Really pleased to work in partnership with lots of teams, facilities, governing bodies. And yeah, if you're interested in working with us, please do get in touch. We've run the Injury Rehab Network events with BASRAT since 2019, and we're really, really grateful to all of the expert guest speakers who kindly share their time and expertise. And the events continue to grow. Obviously, grateful to the practitioners who get involved, and it's really good to see a great number of people online for the event again this evening. Our next event after this one is on the 26th of February with Mike Davison. And Mike's the consultant who works with various professional sports teams. He's going to be talking about organization design principles for performance and medical departments. So please keep an eye out for that. We'll have the registration open for that one soon. But really, really fascinating guest speaker this evening. Ollie and I have just been speaking briefly with John before the session, and hopefully John will sort of share some of the insights into the unique role that he's in, both within the sort of healthcare system and with Leinster Rugby and some of the other organisations involved with rugby in Ireland as well. So John's presentation is focusing on abdominal injuries, and I'm sure you'll really enjoy hearing from John today. So thanks very much, John. Appreciate it. It's a busy time, and really grateful for you getting involved and providing a presentation.
Great. Well, thanks, Ollie. Thanks, Andrew. I guess that's over to me. Yeah.
Yes, please.
And I'm just going to close down the webinar chat, which is still trundling people in from Chicago, hi Sri Lanka, hi Twickenham, hi London. Hi, oh my God, what an international audience. I'm humbled. Yeah, very humbled to be chatting here this evening. And I hope I've pitched this at a reasonable level. You know, it's hard, isn't it? You know, when you truly know everybody in the audience, at what level to pitch something like abdominal injuries in sport. But I'll share you my approach and my experiences, and a little bit about me maybe at the start. So I'm a professor of emergency medicine at St. Vincent's University Hospital inside Dublin, where I am sitting in my office here. It's in the kind of leafy suburbs of South Dublin and the epicenter of rugby, which is my main sport and my main interest in sport, which overlaps significantly with emergency medicine by the nature of sports and sports injuries. So when I'm not here, I'm in my other home, which is in Leinster Rugby, which is only up the road by about 200 meters. And I'm head of medical in Leinster Rugby and been with them for more years than I care to remember now. And I'm also the medical doc for the Irish under-18 rugby team. And they're made up of boys from schools all over Ireland, but a lot of them come from the environs of this centre of southeast Dublin. So St. Michael's College, home for Ronan Kelleher and James Ryan and Dan Levy and Max Deegan and Luke McGrath and um, loads of others, is literally across the road here from as I look out the window, and there's this veritable tunnel that they come across, and I've been looking after all those names of people from knee high to a grasshopper, and then through to their junior cup teams and their senior cup teams, and all the injuries that come with them, whether they be head injuries and concussions, which are so frequent, and I bet you've had talks on concussion too, or their orthopedic injuries, or their MSK, or overuse injuries, or their abdominal injuries. And Blackrock College is a mile down that road, which is the home of Leo Cullen and Brian O'Driscoll and Joe McCarthy and Paddy McCarthy and um, Tom Clarkson and lots of other legendary Lions and Irish rugby teams. So, and it's great. It's a real privilege to be able to treat these players and be involved in looking after them. Such a wonderful professional body of sports people, isn't it? And it's what you guys do as well. You treat you treat the great and the good of sport, and it's a real privilege, isn't it? To be. I try and bring the enthusiasm that they have from their professionalism, their approach, back to my guys here on the shop floor in the emergency department, and share that energy and the enthusiasm. And then, the coaches come to me and they want to live off what happens in emergency medicine. And how do you make those critical decision making skills? When do you know how to cardiovert somebody or resuscitate somebody? Because they see that as, well, what do you know when to make a break from the base of scrum? When do you need to know when to cut in and make a tackle? When do you know when to take a player off because you think he's injured or he's not injured? And so there's mirrors between emergency medicine and rugby, and it's great to have that overlap. And so me and my family are very lucky to buy into it. We eat, sleep, and drink rugby and emergency medicine. And part of that uh, is looking after patients with abdominal injuries. Yeah. And clearly it's not the majority of what I do here. I've got probably the oldest population in any emergency department in Ireland. But it's great to be able to treat British and Irish Lions that are in their 90s, and legends of Irish rugby and other sports. They all live around this area too. So that's a bit about me. In the background and how I got here, I trained in Dublin. I qualified in 1983, which makes this my 43rd year in emergency medicine. Yikes. Um, I did all my undergraduate training and did diploma in sports medicine and diploma in child health, and that was all done. There's somebody trying to break into my office. I can hear the key being turned, but anyway. um, I trained in emergency medicine to the fellowship of the Royal College of Surgeons in Edinburgh. And then I trained in the UK for Hi Anybody from Brighton, where we did 2 tours of duty, and from King's in London, and from Westmead in Sydney, where we went out to work in emergency medicine there and sports medicine, and then came back to Brighton again as consultant and senior lecturer when they were developing the medical school there. And then I've been back here in St. Vincent's for something like 25 years or something now. I've been involved with Leinster and lots of other sports during that time. And really, sports injuries do end up in emergency departments. So they go to, and they come to you guys for rehab appropriately. And you guys make them better. We just kind of diagnose them and give them some pain relief. But you're the guys who really make them better. So along the way, as I said, I've been looking after the Ireland under 18s and the women's teams and involved in the national women's team. And I do match day doctor at the Rugby Internationals in Aviva, which is about a mile down the road here. And did match day doc for the Lions and British and Irish Lions and back in the summer and stuff. So yeah, lots of experience. Now whoops. Let's see if I can make this to work. There we go. Aims and objectives. So we'll just go a quick review of the anatomy of the abdomen. I'm sure, with apologies, if you know your abdomen inside out, but sometimes there's little bits that we forget about. And try and understand the mechanism of injuries and the red flags, because things. One of these key messages is that horrible things can happen to people with abdominal injuries, and they do get missed. So it's good to know. And one of my colleagues here has a great line, which is, "We're paid to be paranoid." And I think that's a pretty reasonable line to approach. And knowing your limits, because a lot of you guys will be working outside a hospital environment, and I'm privileged to have access to diagnostic imaging, to diagnostic blood tests, to colleagues. And I know what it's like to be pitch side, and in that medical room and having people looking at you and being surrounded by a bunch of what if docs and others, so it's tricky. Now, let me see if I can advance. Whoops, go back. Yikes. So that's that. Right, abdominal injuries. So there's your abdominal cavity. We'll forget about the chest and the ribs largely, although, lower ribs, 10th, 11th, 12th ribs can impact on some of the solid structures in the abdomen, and particularly in the upper abdomen, aren't they? Your liver on the right side and your spleen on the left side. And so the sort of things that can go wrong are damage to the solid organs, so that's your liver, spleen, so on, or to hollow organs, or to the mesentery, which is that sort of plastic cling film that brings everything together, and all the blood vessels that run through the abdomen, bringing everything from the heart via the aorta down to the lower limbs. So they're all inside that. And it's a pretty vulnerable area, when you think about it. I guess 16 billion years ago, we were probably crawling around coming out of the water with ribs around our lumbar vertebra, as well as our thoracic vertebra, and probably sacral. And everything inside was encased, I imagine, by a big hard armor. And the abdomen and the abdominal contents were probably much better protected. But we wanted to get up and about, and we wanted to play football and rugby and everything else. So we did a deal with God, and he said, "I'll tell you what, I'll take the lumbar vertebra ribs away, and so you have a bit more flexibility. But just a word of warning, it's going to make everything inside there a little bit more dodgy and available to injury." And unfortunately, that's where we've come. Thankfully, I guess he didn't take the ribs off the thoracics, because I hate to think, what sort of injuries we'd be getting to our heart and to our lungs if we didn't have them protected by the thoracic ribs. So that sort of brief ABC, of the abdomen is your liver, right upper quadrant, the spleen tucked in over here, the pancreas in the middle, the kidneys out here, they're retroperitoneal, talk about them, and the adrenals glands sitting on top of the kidneys. And then lower down, if we include the pelvic contents as being the abdomen, I think it's pretty reasonable to do. There's ovaries, uterus, maybe the testicles. So they're the solid structures, but there's also soft structures, and they're the hollow organs, are they? So you've got the large bowel and the small bowel, and the bladder, and the ureters coming up coming from the kidneys down to the bladder, and your mesentery, that cling film, and all the blood vessels, your inferior vena cava, aorta, going into the iliacs, and all the arteries that are coming off them to supply all the goodies and nutrients to the splenic artery, via the splenic artery, via pancreatic and duodenal artery, and so on. And then I always think it's important to remember there is musculature surrounding all these contents as well, and whether that's musculature in the anterior abdominal wall and the rectus sheaths. But there's also, you think in terms of the diaphragm, and high velocity injuries, typically motor vehicle collisions, in high speed motor racing, can lead to diaphragmatic ruptures, and you can get late presentations of diaphragmatic hernias through that diaphragmatic muscle. So you've got to think about that. Yeah. And you got to think about people playing in sport who've had previous damage, perhaps to the pelvic floor. And this is a real issue now for women playing rugby, and particularly women playing rugby who've had childbirth, who've had pelvic floor tears and pelvic floor injuries, and they're wanting to go back to play um, collision sports where there's high intensity intra-abdominal pressure, and they've got the problems associated with um, pelvic floor injuries. So we need to think about, when you think about the injuries that occur, it's important really to know the contents and the structures. In terms of how often do we see it, I don't see abdominal injuries in sport here every day. I come off a shift this afternoon. I've seen fractured tibs and fibs in sport. I've I've seen shoulder injuries. I saw a shoulder tumor mimicking an injury in a 16-year-old. Um, I saw blunt chest trauma from sport. I didn't see a an abdominal injury from sport this afternoon. I think may have. We see so much in a consultant so much. But just to put that in perspective. But the relevance is hugely important because the consequences of intra-abdominal injuries is far more serious than some of the peripheral injuries that I would see, or dare I say it, even some of the concussions that I'm involved in. So it was. I don't know who thought it would be a good topic to have a review of and for us to chat, but I think it was a pretty good call because the consequences are important and we need to have it to the front of our mind. Those sort of sports is collision sports, really. Rugby, soccer, in this country, Gaelic games, there's curling, which you might know about, and Gaelic football, which is sort of 15-a-side soccer where you can handle the ball, partially handle the ball, American football, um, and then other collision sports, boxing, martial arts. Here's a guy, for instance, who's putting a kick right up to this the black shorts lad's spleen, isn't it? So boxing, martial arts, the abdomen's very vulnerable. Equestrian, hugely important too. We've got a number of horse riding, both sort of gymkhana events locally, and Leopardstown race courses just up the road from us as well. And we get many guys coming from there. More of that later. Cycling, hugely important too, for both coming off as missiles and hitting objects. And then I did see a number of skiing and snowboarding. South Dublin here is kind of slightly affluent, so they're all returning. They've started for the last 3 weeks. They've been returning from France and Austria, in particular the Irish love Austria, with their skiing and snowboarding injuries. Vast majority of which are distal radial fractures and shoulder injuries. But sometimes they come back, and we could talk about that with other injuries. This is uh, Isaac Newton. And to me, he's the real grandfather of sports injuries. And here he is holding his honorary rugby ball. Um, and and the reason I think it's important to maintain him in foremost when you're dealing with sort of all collision sports, but particularly abdominal injuries, because his second law was force equals mass by acceleration. Yeah. So the bigger the force, the more dangerous the outcome of the injury is likely to be. And that force is magnified by two things, by size and by acceleration. So if you're out at the weekend looking after, Tottenham Hotspur under 11s against Crystal Palace under 11s, and two kids knock off each other inside the box and they cry, well, the chances of a significant injury there, particularly intra-abdominal, is pretty slim. probably what you want is a box of tissues, dry the tears, and pat them out again. If you take Will Skelton, who's probably about 150 kilos, and run him into Joe McCarthy at 125 kilos, both running at full tilt against each other, and one maybe with his arms in the air exposing his abdomen, and the other guy tackling him at full tilt. That's a pretty big force. And if one of those goes down, the recipient of that force holding his abdomen, you got to be a little bit nervous, and you got to think, Newton's second law here, and I need to be comfortable with what I'm diagnosing. And so there's lots of different mechanisms of injury. So the main one in collision sports is direct trauma. So we hit by another player, in a tackle midriff by another player. Um, Deceleration injuries, particularly off bicycles, hitting and motorcycles, hitting trees or going on a around. I think if you think of the Isle of Man TT, they all don't die of spinal injuries and head injuries. Some of them are catastrophic intra-abdominal because they hit a pole or hit an object in deceleration, and the mesentery keeps going and tears a vascular. And then there's the instruments, whether somebody falls on a pole vault or fencing, or people who've got or hurleys or hockey sticks. Yeah. Um, we used to have a sport here, which I used to declare was the most dangerous sport in the world, and that was inter-hospital mixed hockey cup competitions, when you would have young girls who were playing junior hockey going out against big ex-rugby players who've been given a hockey stick, and they use it as a flailing implement to kill the opposition. And they'd murder each other. Well, the guys had murdered the small girls, but it was shocking. And I don't think we play it anymore, probably because so many people are getting injured. It used to be the most dangerous sport. Ice hockey is obviously up there, isn't it? Um, then your mechanism of injuries. So we see overuse injuries to the abdomen as well. And that concern about, abdominal muscle, abdominal wall tears. And that can be from either overuse, or weakness and hernias. And then penetrating injuries from often from implements that people are playing sports with. And I put in, last night I put in pathological related injuries, because it's an important part of the body, the abdomen, but it's a place where we've got a doc who does work with us in Leinster, a young guy, and when he was an intern at 24, he got colorectal cancer. Now he's been treated and he's fine, and that's great. But some people have unknown cancers, unknown inflammatory diseases, and some unknown infections, but it would be a bit more obvious. And they can mimic pretty catastrophic injuries, because they've got an abnormal pathological solid injury, or even a hollow viscous. So you just need to be aware in the back of your mind, are you dealing with a well athlete, or are you rehabbing an athlete who's coming back from cancer? And could he have metastases? Could he have liver metastases? Yeah. And be running and participating. We've had an international runner here, very successful international runner, and developed some iron deficiency anemia. And I think medics were treating her with iron, and just getting weaker. And then she had imaging, and she had metastatic colon cancer. And so she's undergoing chemotherapy. So just bear that one in mind. So the direct trauma can be, as I said, a punch, a knee. It can be the consequences of wearing some sports armors, and paradoxically transmitting forces. Maybe some of the guys I'm an avid snowboarder away in Marybelle on Monday, if anybody's over there. And some of the kit that these guys can wear can fall against fall on their ski poles, or fall on their accompanying outriders snowboard. So some of the sports kit that can cause intra-abdominal. Seat belts in participating um, road, whether it be off-road or circuit uh, rallies. Seatbelts are and airbags are fantastic in saving people's lives. When I think back 2 years ago, working in our old department here on the campus, and we'd have 10 or 12 people stuck into a car, and they're all drunk out of their minds, and they crash and there's no seat belts, and the glass is terrible. Oh my God, it was catastrophic, the amount of injuries that we would get. And now we don't see those so much. We don't see catastrophic road. We see the pedestrians, maybe. The guys inside the cars are really well protected. But on occasions, we see the mark of the seat belts, maybe the next day, bruising coming across on the lap belt, of course. And you've got to think about bladder injury and some of the intra-abdominal injuries, which you see. If you don't think about it, you will one day miss it. And then sometimes raised intra-abdominal pressure can lead to bursting of a viscous. And those decelerations I mentioned earlier can tear the mesentery, where you're thrown as a missile, and then you hit a solid object, and your intra-abdominal contents continue to move, and then they're pulled back, and you get a mesenteric tear with a tear of the splenic vessels or the liver vessels. Now, the abdominal wall are constantly see not so much this nasty bruising, but more subtle stuff. So the rectus abdominis is the home of lots of rectal sheath hematomas, and pretty easy to pick up on ultrasound. And it's great if if you're doing pre-hospital sports medicine and with collision sports, having point of care ultrasound, what we call POCUS. Some people call it hocus pocus, but it's POCUS. It's point of care ultrasound, and it's good to be able to pick up and diagnose a rectus sheath hematoma, because they can be very painful and sometimes lead to massive over investigation and perhaps over treatment. This sort of abdominal bruising, abdominal wall bruising from direct trauma, you got to be a little bit more cautious about, because you wonder, well, what could cause this extensive bruising? And so the bruising itself across that abdomen is not so much of relevance, but it's the contents of the abdomen below that bruising that's so important. And so in that abdominal wall, you can get tears and epigastric hernias, which can lead to obstruction. Any hernia can lead to an obstruction. And certainly in the older female athlete, it's not uncommon to see people missing a femoral hernia. So when we see abdominal pain in older women, I teach the guys the place that gets missed all the time is femoral hernias. It's very discreet, it's very small, but can lead to bowel obstruction, which can then lead to all the symptoms of bowel obstruction, a little bit of distension, depending if it's a small bowel or large bowel, abdominal pain, and some of those can lead to rupture. And you're going, well, what's going on here? And people are sort of afraid to have a little peek below the bikini line or whatever, and have a palpator on there. But you do it at your peril for missing those. And then you need to advise your athletes. If you've got an athlete who's got a very large external irreducible direct inguinal hernia, is collision sport the right thing? Or do you say to him, listen, mate, go off and get that done, and then we'll rehab you, we'll rehab your abdominal wall, and you're back playing collision sport? Because that's a big chunk of bowel sticking out there that's very vulnerable. Donal Lenihan, a former Irish rugby captain, got picked for the Lions and missed the Lions tour because at the pre-Lions screening, they said, what's this doing here? This is a hernia. You're not coming to the Lions with that, mate. Go off and get that fixed. So they sent him back to get that fixed. And then previous abdominal wall surgery. is people are prone to getting incisional hernias and Spigelian hernias. So watch for those and be prepared to give your athletes advice if you pick up on a hernia while you're doing, say sit-ups, and the guy's doing a raised intra-abdominal pressure with sit-ups, and you see a periumbilical hernia, then you need to give them advice. The intra-abdominal injuries, the liver is hugely vulnerable. Now I've seen if it's in the abdomen, you can injure it in sport, and particularly collision sports. And I do not think there's anything inside the abdomen that I haven't seen injured in sports collisions. The whole panoply. Liver tears, splenic injuries, upper GI, abdominal walls, duodenums, jejunums, splenic, large bowels, small bowels, bladders, adrenals, genital urinary. I've seen them all, and some with pretty awful consequences. And I suppose, just knowing your anatomy, that the retroperitoneally, so at the back of the abdomen, is where the kidneys lie. And people always feel along, oh, can I feel your kidney there, in front? I get them to bend over and bang down the back. Boom, boom, boom. Is that, oh, Jesus, you got me there. All right. Bang, 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 down. Now that's okay. Do the other side again. Bang, bang, bang. Oh, that was really sore. So now I'm worried about his right kidney because I'm percussing over the kidney. And that you'll see that injury sometimes. Somebody's lying on his side, an opposing player would slide in with his knees, crack off the transverse process of L1, L2, L3, covering the kidney, and contuse the kidney or lacerate the kidney as well. Yeah. So those and the pancreas is retroperitoneal as well, as is part of the duodenum. So injuries to them, fluid will track posteriorly. And so they often won't present, with anterior abdominal wall pain. It might be a deeper pain, and a deeper pain posteriorly. And if you're very soft and nice and pressing on the front of the tummy, they'll go, yeah, I'm kind of okay there. But if you attack them from the back, you go, hold on a second, there's issues going on here. And so then there's those hollow viscera injuries, whether it be the stomach that you can get an injury from, or the large bowel, small bowel, and bladder. We see marathon runners all the time presenting with hematuria because they've got a full bladder. They're running a marathon. They're afraid of getting dehydrated. They drink lots of bottles of water, and they fill their bladder. And this bladder with 100 mils of urine is flopping around and traumatizes the bladder. And then they freak when they get to the end of the race because they present with hematuria. So, or even when they're practicing running. So just so that you're aware of. And of course, there's the intra-abdominal vessel injuries. Typically, again, high speed injuries, and you get a deceleration. If you get a sudden deceleration injury and you tear your intra-abdominal aorta, it's going to be fatal. Okay, if you tear in a collision, if you tear your thoracic aorta, it's fatal. Yeah. When you do injury codings, and you code somebody from an injury of 1 to 75 in terms of severity, you can get the 3 most injured parts of the body, and you get the worst injury, and you code it, and you square it. So you might be the worst you can be for any region is 5. Square that's 25. Another area, say the chest, you square that 25, and then you do the head. It makes a subdural. You square 3. That's 9. So it's 59 is out of 75, and that'll be really major trauma, real trouble. But a torn thoracic aorta is an automatic 75, as is decapitation, because you don't survive either of those. So important vessels going through, punctured vessels that will leak, and you might become hypotensive from, and get a little bit of clot on it. And then you reperfuse the patient again with blood or with crystalloids, and they blow away that clot, and they start to bleed even further. So you've got to be wary of those. of the intra-abdominal injuries, probably one of the more common ones is the spleen. And when I were a lad, as you would say in Yorkshire, whatever, we took out everybody's spleens, and we don't do that anymore. We try and preserve splenic injuries, um, and even in the really sick people, we kind of try and hold tight. And we get an image, we CT them, whatever, then we go, God, look at that, look at all the blood they've lost from that. But we desperately try and hold on. And sometimes we miss it, and the patient becomes too shocked, and we have to go after that. So be very wary of splenic injuries. And sometimes you can get a splenic hematoma, and they'll be sore around that area. And you go, oh, yeah, well, you're okay. You look all right. And maybe you just bruised your ribs. And then a week later, he says, yeah, my ribs are a bit sore, but I can play. And too much jigging ruptures the capsule on the spleen, and they bleed like a stuffed pig, lots of blood. And they collapse and become shocked. So it mightn't be a ruptured spleen, but it could be a hematoma on the spleen, which then has a late rupture, maybe a week or 2 weeks later. So be very wary of those. And I think imaging of those is important. There's red flags with any of these, whether you come upon somebody, in Maribel with a skiing injury, or whether it's pitch side. And so anybody with, an inappropriate tachycardia. So if you're playing wing in a Heineken Cup final, you've no right running around the pitch with a heart rate of 80. You should be up there 110, shouldn't you? So it can be tricky when you go to see a patient. Is appropriate tachycardia for the game that he's in? Or have you taken him off, and is he in the medical room and he's still got a tachycardia of 110? That should have settled. Like, he's not been running around the pitch for 20 minutes and he's still got a tachycardia, and his blood pressure feels a bit weak and thready at the wrist, and then he faints and he looks crap. He's sweating and he looks pale, and now his pain is getting worse. They're the red flags, of an intra-abdominal problem. You get those, that's when you need to be worried. This guy is not going home with the girlfriend. He's coming to see Uncle John in the emergency department, right? They're the red flags with somebody after a blunt abdominal trauma. And then, if you're concerned specifically about some organs, if he comes to you with blood in his urine, hematuria, or a big swollen scrotum, then you've got to be worried about scrotal hematoma or scrotal injury, and they need to come to hospital as well. And so the examination is understanding the mechanism, looking at immediate versus delayed symptoms. How is the pain only coming on since you finished the game, or since you finished that bicycle ride? Yeah. What sort of protective equipment were you wearing? Yeah. Have you been well lately? So this thing about glandular fever and enlarged spleens, for instance. You're coming back from. Did you get an ultrasound before you came back to make sure your spleen had returned to normal? You didn't. Okay. So and now he's presenting, and because maybe he's got a pathological spleen. Yeah. And so so that history is important. The vital signs, that's his pulse, his blood pressure, his respiratory rate, because if he becomes hypovolemic, if he loses his blood into his abdominal cavity, not only will he look a bit pale, but he'll compensate because he'll become what we call acidotic. His respiratory rate will go up as he tries to blow off that acidemia from his hypotension. So watch the respiratory rate. And then palpate along the abdomen for tenderness. Yeah? If it's up in that left-hand corner, then your money's going to be around spleen. If it's the right-hand side, your money's going to be around the liver. If it's painful along the back, you're worried about a retroperitoneal bleed, or a damage to the kidneys, or to part of the pancreas, maybe. So you're looking for those vital signs, the palpation, and that guarding where he really doesn't want you touching his abdomen. Then you got to think, is this bowel? Yeah. Or when you press and you let off, he goes, oh, Jesus, that's worse. That's rebound tenderness, where you press and you let go. And that's a sign of peritonitis. Has he had a perforated bowel, for instance? Yeah. If your doc or you have access to ultrasound pitch side, it's very helpful. In our Leinster room and in the international room in Aviva, we've got point of care ultrasound, and that's helpful for looking for what we call the focused abdominal sonography and trauma, that fast approach. So if somebody's had an abdominal trauma, and we ultrasound them looking for flea fluid. If we do, you really need better visualization, and that's a CT scan. Or if you have a high index of suspicion and you don't even have access to ultrasound, these people need a CT scan. I can't think of the number of people, crikey, that must have been on my learning curve when I was starting out, and were martyrs to my learning curve when I didn't have access to ultrasound or CT. Probably loads of people had splenic ruptures and still have splenic ruptures that get missed and never get diagnosed, and the spleen recovers fine. Yeah. But if you see free fluid on ultrasound, you need a CT, and then sometimes you might need an MRI. So that free fluid, it's once you get used to it, there's a steep learning curve, because when you start using ultrasound, you kind of go, well, it's not like 2D or 3D. It's not necessarily intuitive. And it's a lot of gray stuff and black stuff. And black can be air or free fluid. And say that doesn't really look like a liver. And how does he make that? How do you make that the right kidney out of that? Yeah. Um, but once you've done a small number, you become it's very quite proficient with ultrasound, and we train all our trainees here in emergency medicine now for on fast trauma, the focus of abdominal sonography in trauma. And this is the sort of thing that you'll see then in a CT scan with, say, a liver injury. So this across here is all blood that shouldn't be there. So where does it come from? Well, this is your liver. And in the old Sesame Street analogy, one of these things is not like the other. One of these things just doesn't belong. So this is the mess down here, which is your mushed liver. So he's got a damaged posterior part lobe to his liver. Anterior liver is okay, but he's bled from that, and he's bled quite a serious amount of blood, and this is something that's going to need urgent theatre. And you can see extensive amounts of blood on the opposite side or around the spleen as well, and that's the value of CT. And we have a CT scanner in our emergency department, which is operational 24/7. And so somebody who comes in with a high risk, then we're straight into CT. An MRI is valuable particularly for your elite athlete, when you're kind of going, God, he's really tender over his abdomen. I wonder, is it a strain? Has he got a hernia? And there's a picture of an abdominal wall strain with some bleeding on an MRI, and this is right up your territory now, isn't it? It's anterior abdominal wall rehabbing for an abdominal wall strain. And we're lucky obviously to be here so close to all our centres, but to be able to do a full blood count to check and see if what his hemoglobin is. Normally should be 13 to 15 or 16, and suddenly you find, gosh, this guy's got a hemoglobin of 9. Where's his blood gone? Yeah, has it gone into his chest? Has it gone into his abdomen? Did he leave it on the side of the pitch from a bleeding head wound? And then we use a venous blood gas. Now, you might be used to using lactates as part of the physiological assessment and rehab of athletes, and we use lactate for diagnosing patients who are in shock, whether that be hypovolemic shock from loss of blood, loss of fluid, or septic shock or neurogenic shock, basically where vital organs are being underperfused. Then you start to metabolize fat and create lactate or lactic acid, and your lactate goes up from 2 to 3 to 4. So if we have a player with a lactate of 4, we start to get seriously concerned about is he losing blood, and where is that happening from, and particularly in the concept of an association with a low blood pressure and a fast heart rate. We'll take a urea and electrolytes. We want to see Is his renal function okay? Or has he got an acute kidney injury, a metabolic acute kidney injury, as well as maybe an anatomical acute kidney injury? So somebody who's been taking too many anti-inflammatories before a game and has shut off some of his nephrons, and then he loses blood, he'll put that kidney at even more risk of becoming dysfunctional and getting a raise in the urea and the creatinine, uh, demonstrating a poorly perfused kidney. And then the amylase, vitally important. You know, it's the one test, even my boys and girls out here, they're always forgetting to put on the amylase. And the amylase is a reflection of the pancreas. And somebody can get a pancreatic trauma or pancreatitis, your amylase is going to go up. And if you forget to look at the amylase, you might go, oh, this guy's okay. And then he's back in the next day with worsening abdominal pain. Somebody does his amylase and it's now 5,000. And you go, oh God, how could I forgot to do the amylase yesterday? Yeah. So the management principles in managing our intra-abdominal. So if you get a guy with a nasty enough intra-abdominal trauma in collision sports, also got to worry about the other things which can be just as critical, and they're spinal injuries. So, you know, the approach that airway, breathing, circulation. Is his airway okay? Airway with cervical spine immobilization. Yeah. Be breathing and ventilation. If he's not breathing, he needs ventilation. Circulation and hemorrhage control. Can you give him blood at the roadside if it's a high-speed motorcycle, Isle of Man? Can you give them blood on the roadside? Can you stop that bleeding? If it's external hemorrhage, yes. But if it's internal hemorrhage and he's a large macerated liver like we just saw, you're not going to be able to stop that roadside. And so you have to get him to somewhere really quickly, whether that be to a trauma center or to a center that has the diagnostic and the therapeutic facilities to do a laparotomy and stop the hemorrhage. If you don't, the patient's going to die. So for those players that have subtle injuries, re-examination massively important because some of those signs can be subtle and slow to develop. So re-examination, and you're going, God, I saw this guy earlier. He's much more sore now. Yeah? Just when I thought I was going to let him go home, but I'm not going to let him go home now because he's getting worse. He's much more tender. Intravenous access for intravenous fluids or bloods important, and anybody who's got a critical, potentially critical intra-abdominal injury needs oxygen and appropriate analgesia. What sort of analgesia? They really need intravenous morphine. That's what I use, you know. They don't need diclofenac or paracetamol. If they've got a significant intra-abdominal injury, that's what they're going to need. And then, you know, as rehabbers, you know, it's important you're working with coaches all the time. Tackle techniques is important. Last thing you want to be is losing one of your. We've lost 3 loose head props in Ireland. Snow Shores coming into the Six Nations next week. They're all Leinster players with injuries. And we're constantly re-looking and say, well, what are we doing with our injury rehab to make sure that doesn't happen again? But we need to be talking to our coaches too about tackle techniques and how to prevent getting injured and so that you don't lose players with intra-abdominal injuries. Yeah. And the governing bodies have responsibilities, whether they, you know, we've seen that already with the reduction in the high tackle techniques to reduce concussions. And now, a red slide. All the other slides are black. This one's red. So it must be important. And it's there because signs can be delayed in onset. So you've got to be careful. If you're the advisor, if you're the rapid responder, if you're the pitch side person, or that person, go in and see the rehab guy before you go home, get some instructions on what you're to do with your shoulder, whatever. And he's going, oh, my tummy's just getting more sore. Be aware that, you know, a ruptured spleen or a ruptured viscous, a hollow viscous, can be delayed. The onset of symptoms might be delayed, right? So always bear that in mind. So let's share a couple of case studies just to illustrate some of those. Here is a 19-year-old scrum half, and he was tackled scoring a try. and complained of pain in his lower left chest. And they called him a wuss, you know. You should, why didn't you go under the posts, you know? Why didn't you dodge that guy tackling you anyway? So he plays on and then he's subbed off. And he goes into the changing room. And after the game, they're all having their debrief. And he's the guy who faints. And they all have a good laugh. What is your man doing? And fainting and vasovagal faints, they don't happen so much after exercise, they happen all the time here in the hospital when people see a urinary catheter or they're standing watching granddad and they see his blood being taken and they go, oh, I'm going to faint. And then they keel over. But when the blood pressure is up and the tachycardic and so on, it's not the place to faint in the changing room. And the concern then is to be, okay, he's had blunt abdominal trauma, he's fainted, is he hypovolemic? And if he's pale and he's tachycardic, so his fast heartbeat, when his heartbeat should have returned to normal, you've got to be concerned. And so with that guy, we called the ambulance. And when he got to hospital, he had a heart rate of 120. He was hypotensive. His blood pressure was low. We checked his lactate. It wasn't less than 0.5. It was 5.3. That's really worrying. His blood count revealed a hemoglobin of 10.8. That's really low. He's losing blood. Quick ultrasound on the tummy, and there's free fluid in his abdomen. So that's where his blood that's coming from the abdomen. He was hit on the lower part of his left chest. It's got to be a spleen. So we take him to CT. We talk to the surgical guys, and sure enough, he's got this big subcapsular hematoma with some small leakage on the outside of his spleen. And we crossed our fingers and we left him in bed and watched him like a hawk and re-examined him and re-examined and re-examined him. And we actually managed to save his spleen by treating him conservatively. We got transfused. His blood pressure came back up, and we just watched it and we let him manage him conservatively. Or as I said in the old days, we were whipping those spleens out, and that comes without a cost as well, because you're now vulnerable to infections. You need your spleen for infections, so you're now taking pneumococcal vaccinations and penicillin for the rest of your life to do the job that your spleen would have done. Yeah? Then you're certainly more risk of getting infections. Case study 2, this was a real one, a 27-year-old international center. I was on duty in Aviva, and they were running out at halftime, and he said, I'll go for a quick piss. Went for a big quiz and peed blood and freaked. The whole team had gone out, and he's there, oh my God, I'm pissing blood. And he grabbed one of the guys, said, oh, pissing blood. And they ran and grabbed the doc and said, oh, okay. And he had to get the coach and tell the coach, this guy can't go back out, he's pissing blood. And there was a mad scramble to get the scrum half off the pitch to play in the centre for him. And there was a big scramble right on as they were starting the game to kick off. So you never know when, bad news is going to come your way. So he wasn't too sore, but he remembered passing a ball from left to right and getting a big dunk to the left side of his chest. So we brought him down to our emergency department, down a mile down the road to us, and his pulse was fine, his blood pressure was fine, did a point of care ultrasound, no free fluid in his abdomen, but because he had blood in his urine, we did a CT scan, which showed that he had a ruptured kidney. Again, most kidneys now, we've published our papers on renal trauma out of here, rugby-related renal trauma, and all bar one have been managed conservatively. There was one lad had a nephrectomy. It was completely shattered kidney, but most kidneys will be managed conservatively, put on bed rest, and you've got to be very careful with that kidney. Leopardstown is up the road here. 23-year-old jockey, background history of Crohn's disease, fell from his horse getting over a jump, kicked by the horse hooves, dangerous. Remember, they told you never walk behind a horse because they will kick out, and the extensor ability of that rear horse hoof can cause horrendous damage. So he was taken to the medical center because he'd fallen off the horse and he has to get checked out. And he said, oh, my tummy's sore. And the docs were good. They said, right, down to hospital. We've got to get your tummy checked out. And his vital signs were fine. Slightly, heart rate was slightly up. Generalized tender. I think we did a point of care ultrasound on him too. There was no fluid, but he was very tender over that right side. So we did a CT scan, and he had perforated his terminal ileum with Crohn's, so the end part of his small bowel. So he had abnormal bowel. He's not very many symptoms, but he still has an abnormal bowel from Crohn's disease. And when he got that kick from the horse, it burst his small bowel apart. And so we had to do a laparotomy on him and ended up taking out his colon on the right side and the end of his terminal ileum. So I made that point early on. Know your players, and if some of them have coming back from injury or illness or have things like cancer, remember some of that disease may be vulnerable to intra-abdominal injuries. Here was a 34-year-old female rugby player, 37, and she had some abdominal discomfort and had an ultrasound and a pregnancy test and confirmed her pregnancy. Alas, it was in her left fallopian tube. So the plan was to do an elective subpinco oophorectomy on that side. So they took out the tube before it ruptured, because if it was getting any bigger, it was going to rupture. And somebody with a ruptured ectopic can be life-threatening because it bleeds massively. So she had that done, and she raced up to her father's funeral and came back and said, "John, the cup final, I want to play." This was 2 weeks after her surgery for her salpingo-oophorectomy. And so they will come to you, your players, after significant trauma induced by medics, and say, "Look, can you rehab my abdomen? I want to play the game." It's a tricky one. And I spoke to the surgeons and I said, well, it was laparoscopic and we thought it was just, it was a wound and the wound should have healed. So she played and they won. And that was great. 2 years later, she said, "This is definitely my last cup final. Definitely. I want to play." Well, okay. Yeah. Okay. You've been playing for the last 2 years, but aren't you getting a bit old? "I'm pregnant." Ah. And I jokingly call our female players, when they say, "I hear you're injured," when they present and tell me, they're pregnant and we can't play. So she said, I'm 5 weeks pregnant, and she's now 39 and she's only got one ovary. So there's not going to be an awful lot more chances to have a kid. And I definitely want to play. Yeah. And reviewed all the literature. And of course, there's no randomized controlled trials done on whether people can or can't play, or they're, with pregnancy. "Oh, would you like to do a study? I hear you're pregnant. Would you like to play rugby on the study? And would you not play rugby?" And so you can't do it. All you can do is advise them. And I thought about it, like all our kids did downhill skiing when they were, like when my wife was 2 or 3 weeks pregnant with them, or 10 weeks and more pregnant with them. So she played and they won. So only two other cases. This one's really important. These kids, they wear down the brakes. So in the summer, they stop the bicycle by turning the front wheel at right angles. And then they fall onto the handlebars, which are already worn down. The discs on the end of the handlebars are worn down. So they have a solid metal pipe, and they fall onto that. And you see where the mark is here in this girl's left upper quadrant there. And they get a bruising. So be really careful when you see somebody with bruising from a handlebar on the abdomen, because they generally, if they've that left a bruise, they've generally done pretty bad damage. And they present later on. She presented after 12 hours vomiting and tender. And point of care ultrasound again, CT, and she had torn the third part of her duodenum. Okay, there's the hole in that third part, 50% tear, and she was leaking posteriorly, extraperitoneally through that, and she's getting sicker and sicker. And she was very remote and away from a center of excellence. She could die from this. So be really careful about people with abdominal wall injuries from handlebars. They are lethal. International. This was an Irish international soccer player, famous guy, Chen Duffy, collided with the goalkeeper. Oh, I'm really sore. Oh, get up, you wuss. And then he nearly fainted. He was pale. He was shocked. His blood pressure was low. He was taken to the emergency department, and he had this type of picture here with a massive hepatic tear as well. Uh, and you see all the fluid on this CT scan, all the fluid around the liver, and he nearly bled out. He very nearly died. So he had an emergency laparotomy, out of sport for 3 months, and this is his actual scar here, where they had to literally reef him open as an emergency laparotomy to get in to pack the liver and then repair it in a second stage operation. Then 2 days later, last one, pole vaulter. That's supposed to say 17 years old, and had done frequent jumps and falls over the weekend. And then on the Monday, she started to be sick and then got some abdominal wall discomfort and tender. And then she was tender down in her lower right iliac fossa. And she came to us, had a high white cell count. Whoops. But negative pregnancy test, really important. Never want to miss an ectopic. But a raised CRP, an inflammatory marker. So the concern was initially had she got intra-abdominal pathology? Had a CT of her abdomen, and what do you know? She had acute appendicitis. So sometimes, what you think might be blunt abdominal trauma might be a medical or surgical condition brewing. And if you're dealing with elite athletes, increasingly we're managing acute appendicitis with antibiotics. And with her, what we did was we treated her with antibiotics, and we didn't go and operate on her. Because if we operated on her and took her appendix out, she's going to miss the tournament. She's going to you're going to be rehabbing her anterior abdominal wall for weeks, and she's going to be delayed in getting back. And we treated her with antibiotics. She got better. 2 weeks later, she competed. Everything had settled down. I had another girl, an international rugby player. I did exactly the same thing, and we lost. So we lost the battle. She got worse, and we had to do an appendicectomy. But we gave it, we thought about it, and it was an option, and we gave her that chance. So look, I'm at the end. Abdominal injuries in the wider spectrum of injuries in sport are uncommon. Remember, an awful lot can go wrong. There's a lot in there. There's livers, spleens, and so on. Okay, so a lot can go wrong, and some of them can be absolutely catastrophic. And be wary because things can go really badly wrong, and they don't all happen immediately. They can be deviously subtle in the way they come on. So have a low index of suspicion during the game, after the game, and on the way home in the coach with your players. Have a high index of suspicion. And if you're anyway concerned, send them to a center that has access to diagnostics, like we have here in our emergency department. Ultrasound, CT, MR if necessary, and somebody who's competent to deal with the complication, whether it be a perforated bowel or viscous, that can deal with that. Then that's just as important. Boom. There you go, Andrew, Ollie. I'm happy to chat. I hope that wasn't too lowbrow, and I got some of the messages across.
No, it's fascinating. Thanks very much, John. I think yeah, it's very comprehensive, and I think it's really interesting to see the links and how the emergency medicine and professional sport both sort of benefit each other. So that's great. I think have you got a minute for just a couple of questions?
For sure.
Yeah. So we've just got two, if that's okay. So Jenny's asked, when you mentioned women with pelvic floor injuries, she was curious, are you referring to the load from pregnancy and childbirth or
Yeah.
additional complications?
Yeah. Particularly, perineal tears and tear of pelvic floor. We've got a good centre locally which are beginning to make a name for themselves for women's athletes in pelvic floor rehabilitation. I'm sure there's, for you guys as rehabbers, it's a massive opportunity to make a name for yourselves there, because there's so many women wanting to play collision sports and sports that are involved with raised intra-abdominal pressure that leads to vaginal hernias, abdominal hernias, leakage during activity, and that becomes prohibitive for them to participate. So it's massively important and under-recognized, I think, for women athletes.
Is that an area where there's maybe some more sort of research and more
Yeah,
guidance?
for sure. And the Irish Rugby Football Union is fostering some really good research out of one of our sister hospitals that adjacent to us, St. Michael's Hospital. So watch this space for that, particularly in the area of rugby.
Okay, no, thank you. And then just another quick one, if that's okay. I think you sort of touched on this, but Maria's asked, how can sport rehabilitators prevent abdominal injuries? And yeah, is there any sort of further advice on?
Yeah, and I think it's about being really close to your coaches and kind of making them aware and using the power of anecdotes to you about, oh, I heard about this guy, and um some of our players are in that vulnerable position as well, and say in rugby teaching your proper tackle technique and spending. We do a lot of time with our elite guys on tackle technique to protect the opposition as well as to protect themselves, and then teaching people how they fall, teaching jockeys how to fall from a horse, and falling away um, from the horse, and not walking behind the horse in the in the horse yard. So a lot of those are kind of sports specifics and kind of niches. But but and making sure your handlebars, for instance, have proper padding on the end of them. Like it's if you've got a niece or a kid or somebody who's worn down those blocks and just spends the summer going around tearing down and using that, oh God, it's a nightmare. You see that they're so dangerous, So it's those recognizing where things can go wrong and trying to take those steps. But if you're rehabbers, then inevitably you're going to be working with the coaches and stay close to them and keep them informed.
Yeah, and I guess it's sort of making sure that athletes are sort of conditioned for the sport that they're doing, isn't it?
Yeah, yeah. Watch out for and when you're examining you pick up abdominal wall hernias. You've got to go and get that sorted out. And being aware of being aware of the subtleties. You may be preventing them happening, but you also got a job, Maria, to prevent them getting worse. So pretty. Yeah, the kind of the two things are my boys here never want to hear is, have you got a minute?
Mhm.
The other one is, do you remember this patient you sent home yesterday? Generally, nothing good ever comes out of both of those phrases. So you don't want to be that one that goes, yeah, I know you're a bit sore, but it was a big game, wasn't it? You'll be fine. Go on home there. Take two paracetamol.
So
Yeah.
yeah, I guess
Um,
there's a role for sport rehabbers in looking out for those red flags.
yeah, because docs, I tell you, it's docs will miss them as well.
Do you have time for one more?
Of course.
Okay, last one. So Todd's asked, what's your experience with sports hernias and what are your key thoughts for diagnosis and care?
Yeah. So we see a lot of uh sportsman's hernias without obvious visceral protrusion. Yeah. Um and we use a girl Mushka in Germany, in Munich, and we fly our guys over there and she does a mesh repair same day. It's class. She does a really good job. And so we use a lot of them, her for them. If they've got a clear hernia, then yeah, we use some of our local surgeons, and they need to be done. You can't be playing collision sports with a hernia. Your bowel is it's a vulnerable bowel, and it's going to get hit, and it's going to get bruised, and maybe it's going to rupture, and then all the consequences of intra-abdominal sepsis, and you don't want pelvic sepsis if you're a girl either. So it's crucial that you get those fixed. and really periumbilical hernias too. If you don't get it, if you don't get it fixed and you go on tour and you're, with the Lions in Auckland or Brisbane, and you now get a small bowel obstruction, and you're getting surgery done by some guy you're remote from, thousands of miles away. Um, you want to get your surgery done in an environment that's perhaps close to your facility. So if you get problems short, intermediate, and long term, your records are there, and the guys know what they've done, and yeah, you get adhesions afterwards. Yeah, we've got all your records here. We can deal with this. But getting a small bowel obstruction because in Johannesburg when you're playing the Lions because you didn't declare your your periumbilical hernia, it's a bit foolish. If you run into a problem out there, then.
Yeah, no, that's great. I think we'll wrap up there, John, if that's okay.
Yeah,
Thanks.
I hope those help. I'd love to see all your faces, and it was fascinating in the beginning to see where everybody is. As I said, at the start, well, there's 280 there. I'm humbled to be in the company of such a really important group of people in sport. So I hope you've got something out of it. Thanks very much for your time.
It's brilliant. Thanks, John, and thanks everyone for joining as always. It'll be a bit of an abrupt end. So yeah, no, really appreciate your time, John. Thank you again.
Bye.
All right.